Hi, I am Eva Gerdts, professor from University of Bergen in Norway, and I am here together with Professor Isabella Sudano from the University of Zurich, and our guest today is Professor Angela Maas from Nijmegen in the Netherlands. And we are here to discuss sex differences in hypertension. So, Angela, why did you become so interested in sex differences in coronary artery disease?
Well, in my training in the 80s, my training in cardiology, the standard patient was a male patient, and many women just didn't fit in that model. Women had less obstructive coronary artery disease. The diagnostic pathways that were developed to diagnose obstructive coronary artery disease were not suited for many of our female patients. So there should have been a different pathophysiology, and also the patients were not happy any longer 30 years ago with, incomplete answers to their symptoms. So I had to change the way of thinking about female patients.
Yeah, Angela, this is very, very important, and we are pretty happy to have you here in this discussion. So let's start. What do we know about sex difference in risk factor for coronary artery disease?
Well, of course, we have the lifestyle factors, we have the traditional risk factors. But if you look, for instance, at smoking, smoking has almost a twofold higher risk for myocardial infarctions and strokes at younger age. If you compare the risk in men and women below 55 years of age, the smoking women have a twofold higher risk for an event. So at older age, the difference in risk dilutes. And what we also know, if we look at the traditional risk factors, that below, let's say, 55 years, in general, men more often have higher blood pressure, hypertension, and elevated cholesterol levels. But after the age of 55, this reverses. And when we look at older age in the patient group above 70 years of age, we see that female patients have a higher clustering of traditional cardiovascular risk factors. So that's an important difference. So it's not only the sex difference, but also a difference within age groups among men and women.
Well, as you pointed out, there are differences in the traditional risk factors for cardiovascular disease, but it was recently pointed out also in the literature that actually these traditional risk factors are more like risk factors for a type 1 myocardial infarction. So, could you say something about risk factors for type 2 myocardial infarction? That is twice as common, I guess, in women compared to men.
That's right. We now tend to call it MINOCAS, myocardial infarctions with non-obstructive coronary arteries. There are different types. The myocardial infarctions caused by spasm in the epicardial and or microvascular coronary arteries, but also coronary artery dissections. We know now that in women below 60 years, at least 25% of all MINOCAS are caused by a SCAD, a spontaneous coronary artery dissection. And we know within the group of SCAD patients that 90% of them are women, and that about 25% of them, or one third, have hypertension, but no other traditional risk factors. But when we do an appropriate screening afterwards of the renal and cranial arteries, we see that about 30 to 40% of SCAD patients have signs of FMD, fibromuscular dysplasia. And in other MINOCA patients caused by vasospasm, we know that chronic inflammatory diseases are risk variables for coronary vasomotor dysfunction and vasospastic myocardial infarctions. So, but also in those patients, the traditional risk factors will contribute. It's not or, but it's often together. And we also know that the plaques are different in type 1 and type 2 myocardial infarctions. In type 1 myocardial infarctions, there's a plaque rupture and thrombus formation. This is a bit a traditional myocardial infarction. But in type 2 MINOCA patients, we more often have erosive plaques with peripheral thrombosis. So the pathophysiology is different among patient groups and also age groups. We see the MINOCAs in women most often between 40 and 70 years. That's the most important group of patients. And at older age, the traditional risk factors dominate, and also the type 1 myocardial infarctions.
Thank you, Angela. You touched a couple of times the myocardial infarction and risk factor in young women. And the epidemiological studies show that there is an increase in diagnosis of myocardial infarction in young women across different countries. So we can optimistic saying, okay, we are doing better. We recognize the symptoms of a myocardial infarction better in young women, but are there other underlying factors for this observation?
Yeah, I think we have to bear in mind that the time frame that we're living in is more demanding also for female patients to combine the household, the children, but also a career in jobs. And this is now quite different from 30, 40 years ago. So many women have a lot of work to do, and the factor stress is getting more and more important. But also climate change and noise, the way we live, also causes chronic inflammation, which is also the basis for MINOCAs, for instance. So stress is an equally important risk factor as hypertension or diabetes or dyslipidemia or obesity. And, the way we live nowadays is more stressful than it used to be. And women deal differently with stress than men. Men, they can park stress until the next day and look at a football match and have a beer. But women with stress, they keep on stressing the whole night. So that's an important difference.
Oh, some wonderful points you had there, Angela, I must say. As you know, I've been very interested in how the hypertension or the blood pressure damages the heart in silence, so to speak. So we are more into preclinical disease, so hypertensive heart disease. And what has evolved over the years is particularly that women are more prone to develop these different types of hypertensive heart disease, that left ventricular hypertrophy or a dilated left atrium. So could you say something about about what these sex differences in hypertensive heart disease has for an impact on the clinical disorders that we see.
Yeah, you're right that the impact of hypertension on end organ damage seems to be more severe in women compared to men. And I think there are several factors involved with that. We don't have a clear answer yet. But in the first place, when we measure high blood pressure in a male patient, we call it hypertension. And in women, we tend to call it stress. And even women themselves, they also always have an excuse or apologize when their blood pressure is elevated at the outpatient clinic. So they don't believe they have hypertension, and also their doctors are not so willing to start medication as they do in men. So there's also a conception in the heads of doctors that it happens more often in men. But in addition, of course, women have a smaller diameter of their arteries. And we're starting now in the literature, the discussion, and also in the paper that you shared, Eva, that it may be that normal values of blood pressure should be lower in women compared to similar aged men to avoid the more severe end organ damage. But I think we need to look more into the large data sets that they are present, but it may be that within 5 years' time, we will have different normal values with lower blood pressure values being normal in women compared to men. And so, and if we look at hypertension worldwide, it's on every continent. It is the most severe cardiovascular and deadly cardiovascular risk factor in women. So we have to take it more seriously, and we have to notice the women more earlier who come with premature hypertension. And those are often the women that have coronary or cardiovascular disease in their families, who had a few miscarriages in their pregnancies, who had hypertension in one or more pregnancies. Those are the women who start with hypertension, higher blood pressure values early in life compared to other women. So it's important to compare women and men, but it's even more important to select the women who are prone to develop premature hypertension early in life. So to discriminate between low risk and high risk women.
Thank you. We are talking a lot about myocardial infarction, hypertensive heart disease, and both have in common that can lead to heart failure. And it's known that in women, some risk factor, hypertension with others, are more important risk factor than in men. Why is it so?
Well, for instance, one of the most important risk factors to develop HFpEF, heart failure with preserved ejection fraction, is hypertension, which is in many women also combined with diabetes, and the combination is even worse than only diabetes or only hypertension. And we know that HFpEF is still a very underdiagnosed because, many physicians haven't learned from the start how to diagnose HFpEF. And to see the early stages of HFpEF, you need, for instance, echo with knowledge of the appropriate criteria. And it may be difficult to see it properly. For instance, in women with overweight or large breasts, it can be difficult to diagnose HFpEF in a good way. It's often easier in men. So there are barriers for early recognition of HFpEF. So often the diagnosis is made at a late stage when women are over 70. And then, they have severe symptoms and impairment of their physical condition.
Yes, you have talked a lot about how women perceive the information that they have high blood pressure and try to explain why it isn't the case. And you have also talked about sex differences actually in risk factors that vary across the lifespan or the life course of a woman. So, if you should give some recommendations about how we best can, in a way, identify high risk women for cardiovascular disease in the three age groups, young, middle aged, old, what would you say about this?
Well, I think for this, perhaps women are more easy than men because women have some unique phases in life that can help us to identify higher risk women. For instance, women who start with migraines from their teens and 20s onwards. And this can be a migraine related to the menstrual cycle, yes or no. But we know that premenopausal migraine is associated with a higher risk for cardiovascular disease and also development of hypertension. And then, disturbances, hormonal disturbances premenopausal, for instance, PCOS, we know that it leads to more metabolic diseases and also hypertension. Then the pregnancy problems, as I mentioned before, and also women with an early natural menopause before the age of 40, those are also women having a higher risk. And we also know that women with ongoing vasomotor symptoms after menopause, so the 55, 56 plus women who keep having a lot of vasomotor symptoms, those women also have a higher risk. And often in all those women, cardiovascular disease is also, and risk factors, is also more present in their families. And what we can do nowadays, we have done a study in women after preeclampsia. We have done coronary calcium scores with a CT scan at the age of 50. And in normal low risk women, you won't see any coronary calcium at the age of 50. It's normal to get a bit of calcium deposition after the age of 60, 65, but not at the age of 50. And we saw in women after preeclampsia, in 1/3 of those women, already coronary calcium was present at the age of 50. So a CT scan with a calcium score to identify higher risk women is quite easy to do. It's cheap, it's quite easy to perform, and it helps us to identify the high risk group of women just at middle age. So we have all kinds of possibilities now in our female patients. And I must say that I think it's about 7 years ago that I did the last exercise test in one of my female patients, because at middle age, exercise testing is not very helpful in women. So I think it's getting more and more a bit of a useless test for this indication also, and identification of high risk women. It's not useful at all.
Thank you so much, you both. It was an intriguing, a very interesting discussion, and we learned a lot about traditional risk factors, which in young age have a stronger effect in female than in men, and this change with the older age. And the role of stress is pretty important for young female as non-traditional risk factor, let's say, and especially is linked to the role of female and to the way to cope with stress, which is different in male and female. The hypertensive heart disease is also a point that I keep in mind, this delay in the diagnosis and therapy that may play a role. So this say, okay, no, maybe it's hypertension, maybe not, let's wait and see. This kind of clinical practice should be forgotten. And then heart failure, the FPEF, sometimes we say, is the small female heart disease. And but there are quite a challenge in diagnosis, and especially in early diagnosis when the female doesn't present with heart failure symptoms. So your message to reduce the cardiovascular complication in women with hypertension is, of course, early diagnosis and a therapy which is started so quickly as in men. And I think concerning Minoka, for example, is also to stop to talk about atypical symptoms. There are no atypical symptoms. There are female symptoms. They are
characteristic symptoms for the underlying problems. So, for instance, if you have spasm in the coronary arteries, which is quite often present in some symptomatic women at middle age, you will have a bit of fluctuating symptoms, crescendo, decrescendo. And, it's quite easy to understand that this mechanism is present when you talk to patients.
Absolutely. So it was a pleasure to discuss with you this interesting tema. I thank you, Eva. I thank you, Angela, for your participation. And I thank you all for listening. Have a nice evening.
Okay. Bye-bye.